morning, good afternoon, good evening. I'm very happy to see you all in this virtual room and to welcome you all to our microsurgery update. Very nice to know you all, to see you all. You are all healthy. And I believe many of you are in the stage of recovery with your COVID-19 outbreak in your own country. But some are still in a difficult time, so it is good for us to meet here. And today, we will have one of the giants of the world in microsurgery, Professor Koshima. Now, allow me to start with the introduction. Before I greet Prof. Koshima, so this is the 7th ICTEC online microsurgery update, which start today and presenting Professor Isao Koshima with us. We really appreciate if you do not take pictures, especially with some of the video and photos that bear some copyright. So we do really appreciate if you give best appreciations to intellectual property right. And for a short disclosure, myself and Professor Koshima do not gain any financial interest. This is purely for educational purposes. So this event is organized by the Indonesian Clinical Training and Education Center, which is basically a simulation center or a skills lab under the flag of Cipto Mangunkusumo Hospital, the top referral hospital in Indonesia, and also under the flag of the university, Universitas Indonesia, both resides in Jakarta. So this session is endorsed by the Indonesian Associations of Plastic Reconstructive and Aesthetic Surgeon and by the Indonesian Society of Hand and Microsurgery, as well as the International Confederation of Plastic Surgery Societies. And this is very proud of us that this is the second, this is not the first, but the second event that is endorsed by the APF-SSH, the Asian Pacific Federation of Societies for Surgery of the Hand. So everybody knows Professor Koshima. He is a professor who provide many innovations in the world of microsurgery. As you know, and if I recall, there are some important flaps that are already been worked.
I'm sorry, I think there's a disturbance. Please wait for a while.
Okay, sorry for the disconnection. Okay, so I repeat that Professor Koshima is the creator for DIEP, ALT, GAP, SCAPE, etc. He is also the founder for the technique, what we call or what we understand with Supermicrosurgery. And he also the one who introduced LVA, the lymphaticovenous anastomosis. That would include also his inventions in vascularized nerve flap, appendix free flap, and many more. So Professor Koshima is now the president-elect of WSRM, the World Society of Reconstructive Microsurgery, and people knows that he is the founder of international course for Supermicrosurgery. Prof. Koshima, good morning in Japan. This is like just in Jakarta. Let me just unmute him.
Hello, good morning. Now Japan 10 a.m. So it's a very beautiful day. It's,
Good.
nice, yeah. And also Corona is, gradually decreased. Hiroshima, no Corona patient for this maybe several weeks.
Oh, beautiful then.
Yeah,
Good island without affected by the coronavirus.
yes.
All right. Are we ready to start with the lecture?
Yeah, thank you.
Okay. Thank you.
Hello, everybody. Today, I'll talk on the new era from supermicro to nanomicrosurgery. Nowadays, I'm going to the nanomicrosurgical field. This means a new revolution of microsurgery is now started. So before my presentation, this is the COI. Publish a new textbook on microsurgical treatment for lymphoedema, history and also detail of surgical treatment of for the lymphoedema are described in this textbook. This textbook would be easily available by the Amazon, so everybody can read and learn the detail on the lymphoedema. So this was established the classification of the Power graph, established on the maybe late 90s in PRS. So power graphs are classified as conventional long vascular pedicle graft and also short pedicle, T pedicle with a big vessel. So this is very suitable for flow through vascular anastomosis, especially suitable for the lower leg reconstructions with the flow through vascular anastomosis. And the middle one is true perforator. So many times this perforator has a big size over the 0.5 millimeter or sometimes 1 millimeter. In those cases, the vascular anastomosis is easier with the standard of microvascular technique or supermicro technique. And from now, even less than 0.5 millimeter, 0.1 millimeter, this kind of true perforator could be anastomosis with nanomicro technique. So anyway, this true perforator graph would be popularized in the next 10 years. And time for the free flap transfer would be maybe less than 2 or 3 hours. And sometimes under local anesthesia, free flap would be finished within several hours. So this true perforator flap is a very important problem. Also, with a super or nanomicro technique, this nerve flap or nerve bypass, this concept will be popularized next 10 years. On the lympho bypass, less than 0.2 millimeter could be popularized with a nanomicro technique and free capillary perforator flap. Also, capillary anastomosis or capillary perforator would be popularized from now, and arterial or venule anastomosis less than 0.3 millimeter will be popularized. Many feeding vessels are or venue for basal flap and basal lymph flap, such as small organs. These are very small, tiny feeding vessels. Could be anastomos with a nanomicro technique. So with a nanomicro technique, invisible surgery will be popularized. Also, maybe someday, cellular surgery will be popularized. Cell membrane, incision, and suture will be popular with this technique. Vascular cellular transfer with the feeding vessel anastomosis. But knowledge on super or nanomicroanatomy is not yet popularized. Only few knows. So this supermicroanatomy is necessary for a young generation. This is the we are doing using a whole microscope, and for supermicrosurgeon doing the lymphovenous anastomosis and the local anesthesia for bilateral edema. This kind of nanomicro or supermicrosurgery will be popularized from now. Maybe.
Sorry.
Also, this is the standard 100 micron needle, and now everybody using this 100 micron. And super microsurgeon can use this 50 micron 12 ball. The length of the needle is 3 millimeter. So super microsurgeon can use this 15 micron, 3 millimeter in length. This technique is very useful, but maybe 10 years ago, this nano micro needle, 30 micron or 40 micron, they're 1.5 or 1 millimeter in length, completed. So at this stage, I defined the nanomicrosurgery mean this only 1.5 millimeter, 40, less than 40 micron needle. So nanomicrosurgeon can use this very small, tiny 40 micron, 1.5 millimeter needle. So young generation will use this nanomicro needle, but anyway, probably within several years, micro robot will be available. So with a micro robot, nanomicrosurgery will be popularized. Very easy. No need to use a human hand. Robot hand can manage to use this nanomicro needle. Also, this is the supermicro instrument mainly used for the over 50 micron needle, 12 ball. But also this is a special needle holder for nanomicro to catch over the 50 micron needle, 3 millimeter in length. But now I completed the nanomicro instrument to catch a 1.5 millimeter needle, less than 40 micron needle. So with this conventional supermicro needle, it's impossible, nanomicrosurgery impossible. So new nanomicro instrument is now complete. So probably several years later, you can use this special nanomicro instrument. But today, I can show you this nanomicro instrument. maybe next time. So this is the already established in the European country, MUSA robot assisted microsurgery. So probably with the use of this micro robot, maybe super micro will be popularized, but nano micro is maybe possible. Also, another company in Italy also completed very nice micro robots. So these robots will be opened a new world of nano microsurgery. So this case was done, and 15 years, maybe 3 years after this surgery, complete recovery occurred, and gradually, without any compression therapy, any physiotherapy, lymphedema completely healed up until 15 years, gradually decrease and become completely normal with 6 LVA. So this is the many case year by year. The lymphedema gradually decrease, and especially in the upper arm, this occurs with several LVA. This complete recovery occurs in the upper arm. No need to do the lymph node transfer or other invasive surgeries. Simple LVA, multi-site, and multiple LVA works. So in the upper arm case, this is the biopsy of this case. Biopsy show the smooth muscle cells still remain, especially in the distal area. Smooth muscle cell probably still surviving, but proximal region, upper arm, smooth muscle cell degenerated, but regenerating muscle cell are still surviving, so that's why the functional recovery occurs, especially in the distal area. So the post-operative results depend on this smooth muscle cell. If smooth muscle cell is still surviving, complete recovery occurs with several lymphovenous anastomosis. This is another case. This heavy irradiated and also long time, 11 years. This patient had a lymphedema, but only 2 LVA was established in the whole arm region because this is the 30 years ago. This case was operated, so that's why not so many lymphovenous anastomosis was established. So that, but anyway. This case also needs not the physiotherapy. She didn't cannot do the compression of physiotherapy, but lymphedema gradually decreased until the 8 years. And continuous decrease occurs. So this is the natural cause. Even a heavy irradiated case, only 2 LVA works well. This is lower case after hysterectomy. This case was a very early stage, only 2 months after the appearance of edema. Bilateral, very severe case, a rapid progression. But under local anesthesia, we tried several bilateral knee level. So 6 years after the LVA, this case also showed the very nice result. But lower leg needs compression therapy. Actually, the compression therapy very important. This case was post-operative course until 3 years after surgery. A gradual decrease of circumference occurs, and arrow shows 3 times LV was established under local anesthesia. So bilateral side gradually decrease. This case is also primary case. Even a primary case, LVA works very well. 24 years, this patient had lymphoedema with continuous compression therapy, but it doesn't work. Frequent phlegmon occurs, so we try the multi-site LVA. So result, not until 9 years after LVA, it showed very nice result with only compression, same compression as the previous, before the surgery. So this case shows the sclerosis of the lymphatics, but fortunately, maybe smooth muscle cells still has the potential to regenerate. So that's why post-operative course was very nice. Until 8 years after surgery, the bilateral leg will gradually decrease with a simple compression therapy. So this is the today. I cannot mention the detail of the primary lymphoedema or other very severe lymphoedema. Only the secondary lymphoedema today I'll talk. But this is the summary of the surgery for the lymphoedema. The purpose of the surgery is the salvage of the patient life, because finally, lymphoedema patient died with frequent septic shock. So everybody remember the patient, the death are waiting for the patient. So that's why we must salvage the patient life with surgical treatment. So sometimes, especially in the upper arm, complete recovery occurs, or patient can completely free from the garment. This is the very great advantage for patient in the summertime or hot area. Patient, this is a disaster for the patient. Compression therapy is a very hard disaster for the patient. So complete recovery or release from the garment could be only by the surgery. So everybody try to the LVA or lymphatic transfer. Also, results depend on the remaining lymph drainage function. This means smooth muscle cell function. So we can estimate this lymph drainage function by the ICT injection study, Indonesian green injection study. Nowadays, nowadays it's very easy to find the lymph channel with this ICT injection study, and sometimes in the upper arm case show the complete recovery or normal recovery. Also, even a lower leg case, if LVA was tried in the early stage, complete recovery. Many times complete recovery occurs. But some case in a late stage, advanced case, also show the very nice case. And at least decrease the time of the phlegmon. So that's why LVA, the old case needs a lymphovenous bypass surgery. And especially severe case needs a combined surgery, which means lymphovenous bypass and also functional lymphatic transfer or functional lymph node transfers. Those are combined surgery. Probably next time I will talk on this technique. And also prophylactic LVA, simultaneous LVA with tumor resection, hysterectomy, also breast resection, prevent the lymphoedema. So probably next decade, this prophylactic lymphovenous bypass will be popularized. And also some cases of lymphoedema develop the angiosarcoma, Stewart-Treves syndrome, the very, very high mortality disease. But I have the many cases of only the LVA, this malignant sarcoma disappear without any chemotherapy or radiotherapy. So my success rate, salvage rate is 65% at this stage. So, so please try the lymphovenous bypass with chemo and radiation therapy for this lymphangiosarcoma case. Also, this case is penile cancer, heavily irradiated. So conventional radiopharm flap for urethral reconstruction is impossible because of the post-operative very severe scar. So for this case, with a radiopharm osteocutaneous flap, sensate flap, also appendix, vascularized appendix transfer with feeding vessel, very small 0.3 millimeter. This vascular anastomosis needs nanomicro or supermicro technique. So if you succeed this vascularization of the post-operative urethral passage, very nice, no strictures. And also the sensory recovery is also very nice. This is the published in 90s. So nanomicro, supermicro techniques developed this very nice urethral reconstructive technique. This is also another case. Infected penis repair with the radiopharm osteocutaneous. And also, this patient had a very long appendix, so a whole appendix repair with, including the tecum, extended tecum with the appendix. This is the new technique. So even a short appendix could be extended the tecum. And now the suture. This is the right side show the appendix. And this is post-operative, no stricture of the urethra, also sensory recovery, very nice, 2 years. After surgery, appearance is also very nice. Also, whatever defect will repair simultaneously with ALT free flap transfer, so no functional limitation of the hand. With a super nanomicro technique, this kind of crushed amputation, replantation is also possible under Jita block, 1 or 2 hours. Very easy. With this kind of replantation needs a venue graft for both artery and also vein. Also, this DAP flap, Jita artery power flap, is a capillary powerator from the Jita artery, so no need to transect the Jita artery. This is also a new concept, invisible capillary powerator. Notice this kind of very big flap for finger reconstruction. Also, toe tip transfer with a very tiny Jita artery dissection. And this was done around 30 years ago. That's why the proximal dissection of the pelvic vessel was tried, but nowadays we need not dissect proximal pelvicle. Only this short pelvicle flap is enough with nanomicro, supermicro technique. Pelvic vessel become shorter and shorter. So probably with a jigsaw block, both toe and finger, this surgery will be completed within 7. Multiple vascular anastomosis is very necessary. Not only single, bilateral jigsaw artery and also double cutaneous venous anastomosis unnecessary. This case is a iatrogenic ring finger necrosis after the boral advancement of complete necrosis of one nail occurs. So another hand surgeon asked me to repair this nail loss. So I took the second toenail and transfer with short length, only 1 centimeter of the short length of the jigsaw artery and also cutaneous vein and jigsaw nerve. Other jigsaw block and transfer. So minimum donor site mobility and completely normal nail, normal looking nail. Also, medial plantar perforator is a very, very small, but with this perforator flap, this kind of pulp loss young men who had tenderness of the finger. So medial plantar through perforator flap was pain and the cover transferred to the pulp. And the recipient vessel was jigsaw artery perforator. So perforator to perforator flap, medial plantar, perforator to perforator. The vein was a cutaneous vein transferred. So 4 weeks after surgery, defects still exist, but finally this defect was closed spontaneously. So this is resting basic surgery. So this 1-year-old girl also had a very severe heat injury, heat burn, contracture. After releasing the contracture, flexor tendon exposed and medial plantar perforator, T pellicle, including a T pellicle, was transferred short pellicle and cutaneous vein V1 transfer to cover this defect. So this T pellicle was interposed into the transected jigsaw artery. So flow through vascular anastomosis was performed in this case. So this is the flow through pre-perforator flap. Schema shows the flow through vascular anastomosis. Also, this structural loss, 12-year-old girl, after the tracheotomy, all the cartilage was infected and lost. So patient couldn't remove this tracheal tube for over 4 years. And plastic surgeon and EMT surgeon tried to repair with conventional cartridge graft and the hinge flap technique, but it failed. So flap necrotized and only the wide scar remained. So this is iatrogenic tracheal loss and also a wide scar in the exposing area. Took the full thickness concave flap pedicle with a posterior auricular vessel 0.5 millimeter. And the recipient vessel was thyroidal, intrathyroidal vessel, short pedicle. So intrathyroidal vessel was a recipient, and also complete survival. And 4 weeks later, cannula was removed, and this scar was repaired with an expanded skin flap, local skin flap. So scar was in the concealed area. So ear defect was covered with a full thickness skin graft. So no ear deformities. Left ear was a donor of the concha flap. Also, this case is also a trachea contracture after the tracheotomy. So this case also over 5 years, she cannot remove this tube. So concha flap with preauricular vessel included superficial temporal burst flow, arterial, reverse flow, vascular pedicle, and flow through vascular anastomosis to the superficial thyroid vessel. And this is also the complete survival of this concha. 3 years, no contractures. So also, this defect of the upper eyelid could be repaired with this partial auricular transflow iron superficial temporal arterial flap, but cutaneous vein in the upper eyelid, this is very small, 0.5 millimeter vessel anastomosis was necessary to the superficial temporal vein. So this is post-op, no necrosis, completely survival. The posterior aspect of this flap was covered with oral mucosa, and survival of the mucosa is very nice. 3 years after surgery, no corneal ulcer or no conjunctivitis occurs. Normal looking. Also, this FCC of the oral commissure removed, and iron submental flap transferred to the intraoral region, and the extraoral commissure was repaired with the first wave space flap transfers. This complicated the vascular anastomosis, angular artery, and also submandibular, submental vein, the recipient vessel, and double flap was combined. Repaired this commissure, and the post-op very smart oral commissure repair. Also, parumbilical. This is the parumbilical, true parumbilical flap. DIP true flap is also very used. This concept was published in 1998, PRS, but at this stage not so popular. This donor side abdominal donor side is very nice, and primary departing also possible. So primary thinning and the primary true perforated flap, true DIP flap are very useful for many people. So this is the primary departing and thinning, and the short pedicle, only perforator, true perforator deep flap, parumbilical flap, departing, primary depart, cover this big defect of after the removal of the melanoma. So this case was also published PRS maybe 20 years ago, but this technique at this stage not so popular. Probably from now, this technique will be popular. This also silicone mastitis. She complained of very severe pain, and after removal of this silicone back, the simultaneous to perforate adiposa flap, DIP adiposa flap, paraumbilical adiposa flap transfer simultaneously, and the right thoracic vessel was feeding vessel. So this is the after surgery, several years after surgery, natural breast reconstruction. Also, this young female lost the leg established by Harrock. My chimera is completely different from the Harrock's chimera, so I changed this additional vascular anastomosis, much stage or multiple combination of with supercharged anastomosis. This should be a different naming, so I named the orochi flap, orochi combined flap, single stage or multi-stage orochi. Orochi means the Japanese word of nymphs, old story of nymphs. We had eight-headed big snake, violent snake. So this we Japanese say, or eight-headed big snake, orochi. So I named the orochi flap, originated from the Japanese microsurgical concept. With this orochi concept, we can make this kind of very severe floating sound 10-year-old girl. The position of the this floating sound with iron sound transfer, and also simultaneous tap flap, including a small LD muscle, innervated LD muscle with long motor nerve for a dynamic adductor muscle reconstruction. Also combination free scapular flap, because the pedicle vessel is very short. So once this scapular flap transfer as a free flap, so additional vascular anastomosis is necessary. But this is not a orochi. This is not a skip. Orochi concept is necessary, and the combination in the hand. So scapular flap, scapular bone pedicle was anastomosis to the branch of the thoracodorsal system. Distal end of the thoracodorsal vessel, and also motor branch of the motor nerve of the LD muscle was anastomosis to the single fascicle of the ulnar nerve, and also flow through key portion of the LD muscle was anastomosis as a flow through vascular anastomosis to the transected ulnar vessel. So flow through vascular anastomosis, nerve anastomosis, supercharged anastomosis of the scapular vessel to the distal end of the thoracodorsal system. So this is completely triple component. Supercharged vascular anastomosis. This is the orochi concept, one stage orochi. So post-operatively, this muscle moved very well. So dynamic reconstruction of the adductor function of sound, but the color of the flap is not so good. So patient asked me to change the color. So I changed with a media plantar full thickness skin graft, replacing this skin flap. So this case also severe heat pressure injury of the forearm. So radial bone completely necrotized, also extensor tendons are completely necrotized. So radial vessel also completely necrotized. So everything rejected. Only ulnar bone preserved. So for this, I took the peroneal osteotendinous neurocutaneous flap. So saphenous nerve included to restore the superficial radial nerve. So everything. So peroneal, vascular peroneal tendons, extensor tendon repair, and fibula replace the radius, and the peroneal vessel interposed into the transected radial vessel, radial artery and comitant vein, and the peroneal tendon for the extensor tendon. So one stage reconstruction of this. This is not the dear ology concept, but near similar to the ology concept because of the bilateral vascular flow through vascular anastomosis. This outside the supercharged arterial anastomosis. So this is the kind of also nerve repair was done. And this is the 2 years after surgery. PA joint is not so good movement, but PIP is a very nice movement, shows a very nice movement. This is another case. Young woman, 28-year-old woman had advanced rhabdomyosarcoma, originally from the biceps muscle, so full thickness defect, including the median nerve, 15 centimeter, and also brachial artery loss. Also, distal portion of the distal half of the biceps muscle, also skin defect, big defect. Neuro, arterial, also muscular was defect, was repaired with the LT flow through flap with saphenous vein for brachial arterial loss, and femoral nerve 15 centimeter was also obtained with this true perforator flap. This true perforator flap was anastomosis to the perforator of the distant branch because perforator of this flap was cannot dissect to the proximal descending branch, so that's why the perforator was once transected and anastomosis to the other perforators. And also motor nerve was repaired 15 centimeters. This was a vascular nerve graft, so brachial muscle was connected with the free fascia graft. Also some fascia transfer, vascular pedicle nerve graft, ulnar fascia transfer to the median, transected the median nerve. A motor branch of the forearm muscle, fascia transfer also established. And this is the 11 months after surgery, Chinero sign advanced to the palmar region very fast. And also 1 year and 2 months after surgery, channel sign advanced DRP level of the median nerve, and previous after surgery, no recurrence of sarcoma, and Siemens Weinstein showed the 25 millimeter. 2 PD was 25. And also, but Siemens Weinstein 3.22. This is amazing because this is the nerve flap result of the nerve flap. 15 centimeter with elbow defect. Finally, Siemens Weinstein showed the 3.22 very recovery, also flexor muscle function. This is very nice. So he can grasp the some big object, and the flexion also possible. So he can eat everything with it. So in summary, I proposed some new concept on the supermicro nanomicrosurgery. Past perforator to perforator concept. So from now, I expect the young generation, instead of the conventional free flap transfer, true perforator, using a true perforator and perforator to perforator flap transfer. It would be popularized within several hours and less invasive surgery. I always expect the young generation popularize this new style of free flap transfer. Also, flow through perforator flap. Almost all perforator flap could be used short segmental T flows through perforator flap. So this is very useful. Double vascular anastomosis assure the high success rate. So you can sleep nighttime because either side occluded. Flap showed very nice vascularization. So success rate become a very higher. Also reverse flow iron perforator flap. Also almost all could be available with this concept. Almost all the perforator flap. We can use reverse flow perforator flap, and also the very wide and complex deformity should be repaired with Orochi combined flap, multi-stage, single stage. The important point is the supercharge. The other flap obtained from any other side and announcement to the small perforators. So with this concept, we can transfer 3 or 4, 5 many flap, nerve flap, muscle flap, and also bone flap, many are combined. So this concept is very important for hand surgery and also face. So aesthetic reconstruction, functional reconstruction that would be possible with this new concept. Also cross-oral transfer for established head and neck defect. Even if ipsilateral recipient vessel missing, contralateral recipient vessel could be used with cross-oral pedicle transfer. So later you can cut the intraoral pedicle vessel. So this is also a new concept. And also perforator flap on perforator flap on flap concept. This is also next economic flap transfer. So bulky flap in the first stage, you should use the bulky flap. So second stage, you can use the aesthetic flap on flap concept. So you can obtain the aesthetically satisfied the result. Also, free adipose flap for aesthetic facial reconstructions. Pulsar-based DIP adipose flap and also skip adipose flap is best donor site. Also, nerve flap. This field would be popularized by the supermicrosurgeon or nanomicrosurgeon, and next 10 year, 20 year. So I believe nerve collapse, nerve bypass. Next time I'll talk nerve bypass, change the nerve anatomy. This is amazing. So you can sacrifice a motor nerve with a nerve bypass surgery. So now partial completely salvage with a nerve bypass concept. So nerve, the palsy could be open, waiting for you, young generation, young supermicrosurgeon. Thank you very much for your kind attention.
Wonderful. Now we know that many of us missed of so many publications and work that you have done in the past. Professor Koshima, you're always amazing. All right, so ladies and gentlemen, after knowing all the information that started with publication so many years ago, even though that was not that so popular, now with the new era, with a super micro and then elaborated into nanomicrosurgery, everything will be more possible. I mean, greater possibility for people to work in this reconstructive area. Okay, so before we invite people to ask questions, I think we will use time now to invite you to join our key question sessions, which is good for you to do your self-assessment, whether you grab some key informations of his lecture. So you see the link in the chat box. You can just click the active link in the chat box and then you respond. It's only 3 questions and it's gonna be good for us to know, for you to know yourself. And some more interactive questions would be performed after a Q&A with only 5 minutes of game. Professor Koshima.
Hi.
Yeah, may I start with just a simple questions that many of young surgeons would ask in terms of number of LVA that you decide to treat lymphedema. Let's say, take an example of acute lymphedema. 3 LVA, 5 LVA, 6 LVA, how would you decide that?
Yeah, it depends on the cases. In the early stage, I think 1 or 2 is enough. Upon is enough, but several is enough. But late stage or severe case, we must establish as many as possible, multi-site. Nowadays, I'm trying over 10 anastomosis for very severe case or advanced case or lower leg case. So it depends on the cases. Mild case, only few is enough, but accurate anastomosis is necessary. And also the distal level is very important because in the distal area, smooth muscle cell may be still surviving, but proximal area, based on my biopsy, the results show the proximal side smooth muscle cell already degenerated. So this degeneration or surviving the smooth muscle cell depend on the result. So distal anastomosis and also the number, multi-site anastomosis is very important.
Okay, thank you very much. And do you see that, your number of anastomosis, the LVA, would in line or in relation with the speed of recovery or the speed of the outcome?
Oh,
The
you mean
greater the number, yeah, the greater the number of the LVA, the faster that you could observe the successful outcome.
but you mean the speed faster? What's faster?
Sorry, Prof. Koshima?
I can't understand the question.
Oh, sorry. I repeat my questions.
Yeah.
You see that the greater the number of LVA you perform, would result with the faster outcome you could get.
You mean the
circumference of
the national result when the results appear. Yeah, it depends on the cases. The mild case surely just after surgery, but severe case or the advanced case, it takes several years. Just after surgery, some improvement occur, but actually those severe cases show the more time, 1 year or 2 years, sometimes 3 years. But maybe 10 years later, almost all cases show the very nice result. So it depends on the cases.
Right. Right. Thank you. So, ladies and gentlemen, I believe you finished with your key question sessions. Do you think? All right. Now, let me invite any of you who would like to activate your raise hand button so that you could be given the microphone. We would activate your microphone when you want to ask your question directly. All right. So, one of the promising points that you mentioned is the therapeutic effect to the sarcoma. LVA cures sarcoma and also put the patients into much better immune system, the immune system. So how would you describe how LVA works for treating the sarcoma?
Yeah, this is a very important also. Yeah, very, very, very important. Yeah, point. Today, I didn't mention the detail, but everybody who specializes in lymphatic surgery has a great interest in this point. So
Yeah.
historically, maybe 7 years ago, I happened to watch the complete disappearance of the sarcoma. So because the patients reject the chemotherapy or radiation therapy after appearance of sarcoma, this is 7 years ago. So I asked many times to receive the chemotherapy, but she denied. And 3 months later, she came revisit my clinic, and sarcoma completely disappeared. So I wonder what happened. And I remember the another one case, sarcoma completely disappeared with the chemotherapy and the radiation therapy. So, but usually, the angiosarcoma never disappear with radiation or chemotherapy. It's a common sense for oncologists. So I saw what happened between two patients. So the common factor for these two patients is the previous LVA, successful LVA. So I wonder the previous LVA may activate anti-cancer immunity. So the next several cases, I called the immunotherapist. So I asked him, professor, to confirm the anti-cancer immunity of the preoperative, postoperative. So he showed there is a special he proved the anti-cancer immunity appear after the LVA, only single LVA, anti-cancer immunity activated. This is the probably not so many don't know this mechanism. This is the key word is a checkpoint mechanism. Checkpoint mechanism relate to this change. So this is already proved. But at this stage, I'm not published. I'm not published. So that's why this should be a secret. If someone publish this mechanism, I lost the priority. That's why I can't say the detail. But checkpoint mechanism relate to this surgery. Single LVA, this anti-cancer immunity relate to the checkpoint mechanism activate. And at this stage, 65% of the patients salvage. The longest one survive over 10 years. Total number may be 6 or 7 patients surviving at this stage, but the mortality rate is 95%. So almost all patients die with chemo or radiation therapy.
Right.
So this is amazing. But I must say, at this stage, I must say to the young generation audience, if the angiosarcoma patient with the lymphedema came to your clinic, you should try at least one LVA under local anesthesia and also chemo or radiation therapy. So the survival rate of the patient increase. The patient may survive. So this is a very important point. So this is the maybe be popularized from next maybe 5 years or 10 years. So plastic surgeon can salvage the angiosarcoma with the supermicro or nanomicro technique.
Right. Wow, that's hypothesis that we could set up into, we could elaborate it into a good design of research. I think this is kind of like invitations to people who are interested in the basic science.
Yeah.
Wow.
Basic science is very important.
Right.
Also, I must say, I'm now in this lecture, I emphasize the nerve flap concept. I used to be a neuroscientist. That's why I have a confidence. Also, axonal transport relate to this nerve flap concept. So that's why I have a confidence. I have a specialist of axonal transport. That's why sometimes I'll give you the talk on the axonal transport and also a nerve regeneration and muscle regenerations. So this is a basic science, basic concept is very important to develop new field of the clinical treatment.
All right. So after this lecture, I will be in touch with you to ask for the date for your next lecture then.
Thank you.
All right, Prof. Koshima.
Yeah.
Well, going into technical aspect, you mentioned that one of the example in upper extremity that you put the area around elbow as your primary concern to do the LVA. In lower extremity, you do not concern on the more proximal area, but the whole length of lower extremity would be your site to do your multiple LVA. Is there any philosophical concept in between upper and lower extremity, or is just like a coincidence?
Yeah, this is also very, very important point. You always point a very important point. Yeah. In the proximal region, smooth muscle cell degeneration started in early stage, but distal area the degeneration of the smooth muscle cell late stage. So that's why proximal region, I try the LVA only for the early stage patient. But the late stage or advanced case, if you try to find the lymphatic channel in the upper arm or proximal side, a little bit difficult. And also the functioning is not so good. So first, you try distal area. And if you have a time, try to the proximal. But early stage patient, you should try proximal region.
Okay.
So this is theoretical background, very important.
Right. Right. Thank you. Well, I do not see any people here to ask. To activate the raise hand button yet. Maybe they're too shy, facing directly Professor Koshima here. Ladies and gentlemen, you are all invited to ask questions, because if you do not ask questions, the burden is on my side, and then I will create, uncertain trouble for Professor Koshima. Okay, now in regards of technical aspect again, it's good to know that you several times mentions the type of the T pedicle, which is very short with the perforator. Could you provide the audience with the tips how to get that T? Short pedicle,
Yeah, this is also very important point. So all free flap transfer would be first should be changed to long vascular pedicle to the T pedicle, short T pedicle. So because standard microsurgeon can easily anastomose the T pedicle because the size of 2 or 3 millimeter, big vessel. Also, the great advantage of this T anastomosis is double arterial, also double venous anastomosis assure high success rate. You need not do the re-operation, re-explorations. Also, the flap elevation the belly become a short time. No need to dissect proximal to distal, long length of the pedicle vessel. So all power the flap, deep flap, LT, you should not dissect proximal the long length of the main vessels. But before surgery, you should select the recipient vessel as near as possible. So case should be limited. If the recipient vessel is far from the defect area, in that case, T anastomosis is impossible. But the cancer case, usually recipient vessel exists near the defect. In that case, you should try T anastomosis. Also, this location of the T is very easy. Preoperative echo, echo system, you can confirm it very easily. Also, nowadays, you can estimate the caliber size, and also power rate, size of the power that you can estimate. So preoperative echo system is very important to detect the nice T location. Should try first T and next perforator to perforator. So finally, young generation, young microsurgeon, I expect local anesthesia, free flap transfer with local anesthesia. So perforator, the great advantage of the perforator to perforator free flap transfer is, could be finish under local anesthesia. Okay. So the great candidate is a skip flap.
All right.
So like the skip flap for young generations. Skip flap could be easier under local anesthesia.
Yeah.
Total reflux transfer could be finished under local anesthesia. The skip flap is the best candidate. Sometimes I'll talk on the several hundred cases of skip flap for this maybe 20 or 30 years history. And also top flap. Top flap and skip flap is the best flap. Completely overcome the ALT and DIP flap. Next generation is a skip and top. Sometimes I will talk the long history of my big experience.
Right. So that's very encouraging. Now it comes into a next subsequent questions that you encourage people to do the free flap transfer with or under local anesthesia.
Yeah.
So I assume that you also provide the vasoconstrictor, epinephrine, adrenaline with low concentrations. Does it affect your perforator?
What do you mean? I
The,
can't hear.
The vasoconstrictor, epinephrine or adrenaline that you would include in your local anesthetic drugs to be injected, would this vasoconstrictor affect your perforator?
Yeah. I always use the Xylocaine E. Xylocaine E at the beginning because breathing disturb the because the vasospasm occurs. So if the bleeding occurs, we cannot detect the perforator. So at the beginning, I use the epinephrine, Xylocaine, but maybe after I dissect or find the perforator, so I use the papaverine to stop the spasm. But some bleeding occurs. But so should use both epinephrine and also the papaverine. Papaverine works very well.
Right.
So if you, the other advantage of this drug is prophylactic LVA. Prophylactic LVA is very difficult because the normal lymphatic channel show the very strong spasm, completely different from the lymphatics in the lymphoedema patient. So very, very severe spasm occurs in the prophylactic LVA. So you should use papaverine.
Right.
And you are anastomos.
Yeah, very important tips.
Yeah.
All right. So I got interest also with the concept of prophylactic LVA.
Yeah.
Meaning that the LVA would be performed right with simultaneously with the cancer resections. When you compare with the hypothesis in the future, or I mean your own idea, when you compare it with the lymph node transfer to be put it in a prophylactic area, which one is going to be better in your opinion? Prophylactic LVA or lymph node transfer?
Yeah, prophylactic is better. The simultaneous LVA. But now I finished the paper of prophylactic LVA. I studied prophylactic LVA in the 90s, 30 years ago. But Bocardo, maybe 2007 or 8, he proposed the prophylactic LVA with a breast cancer resection. The difference between both me and Bocardo is the site of LVA. Bocardo in the other microsurgeon tried the axial area, same area of the lymph node resection, but I never do the same area because the cancer cell may contaminate So I always explore the elbow region, distal from the cancer resection.
Right.
And also before the cancer resection, I tried LVA because of to prevent the cancer pollutions. So this is completely different, but the elbow region, very severe contraction occurs, spasm occurs. So this is the little bit difficult to compare to the this same defect. In the same defect, the vasospasm, lymphospasm disappear with waiting the time. But elbow region, I cannot wait because the oncologists are waiting the resection. So short time, elbow is necessary. So this makes it a little bit difficult. But
Yeah.
based on my experience, I have a long history. So no one had lymphoedema, including a very severe case, severe irradiated case, a long time follow-up. No lymphoedema appeared. So probably with accurate technique, maybe 100% of the lymphoedema could be prevented. But probably if recurrence of cancer occurs, lymphoedema may occur, cannot prevent.
Right, thank you. So you got greeting from Bandung named Rani Satrina. She is really curious about taking your advice on how to be such an innovative like you. Do you have advice for the young surgeons to be following your achievements by being very innovative?
Yeah, thank you. This is also every time I want to say the basic science. Never forget the continue the basic science. Yeah, something now neurosurgery or anatomy or such a basic fundamental knowledge is always we should collaborate with the other, also pay attention to the other fields. For example, orthopedic oncologists and neurosurgery, and also pediatric surgery, many, not only fundamental, but other specialists help communicate with the other specialists, clinicians. So every time new fields appear, so curiosity is very, very important to achieve a new field. Also, there are many interesting fields, unknown fields. So only young generation, not only senior, some of the senior guy also has such a, still do the achievement, but young generation around 30 is a key age. In the past, I at the beginning of the perforator, when I was 40s, I started the international course on perforator flap. It's 97. Before 97, no one believed the perforator concept, but we organized the 97. So the first international meeting course was in the Belgium. So only 10,000, 100 young generation around 30-year-old, only 30-year-old come to learn the perforator concept and technique. So those guys now become very great microsurgeon around the 50s. Right. So young age is also very important. Revolution always occur among the young age around the 30s. So probably today, such a young generation are hearing my lecture. So those guys should could make a new revolutionary period. So I always expect young generations.
So good for you who are still in your 30s. Now it's time for you to taking over Professor Koshima innovation. So be active, be
Thank you.
curious,
Thank
and deep into the basic science. I think I would like to just take one questions from Gopi Renganathan. So is it viable option for you to consider venous flap as a
Oh, yeah.
viable option for small defect?
Yeah, venous flap, please read my article published around 90s, British Journal, yeah, probably. So I succeeded big venous flap. This flows through venous flap from artery to vein, near the venous drainage, a very big saphenous flap. The width is 10 centimeter possible, and the length maybe 20 or 30 centimeter big flap. Whole area of lower leg medial aspect could survive with flow through AVV venous flap. So small defect of the finger also other area could be, of course, could be successful, but big flap also possible. So this was published. I succeed the tongue reconstruction after tongue cancer resection. This was published in 90s, British Journal of Plastic Surgery. So this is also succeeded around the same age as the perforator success. Age of middle 30s, I used to succeed the venous flap. Venous flap concept was proposed by senior doctor, Professor Nakayama, in Tokyo University. We ran in the Tokyo University at that time. Professor Nakayama, Yoshio Nakayama, proposed this venous flap concept with experimental work. This was probably the 80, around 80. So already 40 years ago, venous flap concept was proposed from Tokyo University.
I see. All right. Well, thank you very much.
Welcome.
Wonderful. Actually, I have already prepared the game, but I have to make sure whether the game is ready. I need to invite one of my assistants to be ready. Can I have Sasti with me?
Yep.
Sasti? Okay. Now, ladies and gentlemen, let's join the game before we give big applause to Professor Koshima. It's going to be fun for you to join this short session. Over this. the first question. What is the needle size for 12-0 suture? Okay, let's see. Oh, good. Big number here. Correct. Okay, meaning that many of them were really paying attention. Okay, now who's on top? FGT. Congratulations, FGT. Let's move to the next. Second question. What is the proper needle for nanomicrosurgery? Hopefully that everyone got it right. All right, okay. Not all of them, but only 4. Okay, now let's see who's on top. Agung, congratulations, Agung. All right, so let's move to the next. I think that was one of the key information at the beginning. Maybe many of them are coming late during the lecture. Now, what set of instruments do you pick among these choices? You got it right. I hope that 100% would be correct. Let's see. All right, less than half there. Okay, who's on top now? Oh, FGT is taking over. Okay, good. Congratulations, FGT. Now the next. In what year the combined free appendix and radial forearm free flap for penile reconstruction was first released?
This is very difficult.
Yeah, people may not pay attention on the trivial part, but this is the game, you know. Oh, you are lucky. Good. Well, that's good, you know, more than 50%. Now, who's on top? FGT. Oh, wow. We keeps the positions. Congratulations, FGT. Now, let's see the last. DAP flap. Hopefully that everyone remember, which is good for digital reconstructions in hand, stands for
Easy.
Easy, hopefully 100%. People may be confused. Yep. Okay. All right. Now, who's the champion? The winner. The winner is. This is the third place. Stephen. Congratulations, Stephen. Runner-up is FGT, and the top is T-Kong. Wow, the one who asked questions. Yeah, congratulations. So he was asking questions about. Okay, congratulations.
Yeah,
Professor Koshima.
he should be a nanomicrosurgeon.
Yeah, and thank you very much, Professor Koshima, for such a great lecture. Fantastic to show your long year experience that will not really take attention. Not really got attention from the world by nanomicrosurgery. Wonderful. Thank you, Professor Koshima.
Thank you. Thank you, everybody.
Yes, and to all of you, thank you very much. Have a nice day.
Yeah, let's talk the next
Right.
time. I'll prepare more interesting lecture.
Great, great. Oh, you are so generous. You are so generous. Thank you. And
Yeah.
for many of you, see you some hours later with a lecture from Modena, Italy. Professor Koshima, I'll talk to you soon. Thank you.
Okay.
Stay
Thank you.
well.
Thank you.
Bye, everyone.